Good morning, everybody. My name is Dr. Erez Dayan. I'm very excited to have you join our Liposuction 101 course with the addition of energy-based technologies for the face and body areas. During this course, we're going to go through really the basics, the 101 of how we perform liposuction, safety considerations, pre-op considerations, and how we manage patients and complications post-operatively. So I want to give you first a course outline, overview some of our topics, and we do have an in-person course with hands-on training as well that I'll share with you at the end. So the purpose of this course is really to provide you a comprehensive training at a basic level of the essentials of tumescent liposuction, specifically under local anesthesia. Of course, we want to stay safe and proficient, and this is really meant for core and non-core physicians, physician's assistants, nurse practitioners, anybody who's interested in learning the basics of local anesthesia liposuction with energy-based technologies. So the beginning of this course is going to speak to patient selection, preoperative considerations. We want to make sure we're identifying the right patients, and this cannot be more emphasized. I think in plastic surgery, majority of the challenge is patient selection. Execution of the actual procedure is very predictable once we have good patient selection. So I'll show you how we preoperatively evaluate patients, the questions we ask, make sure we're staying safe, and you know the clearance guidelines to make a patient a candidate for this type of procedure, including indications and contraindications, as well as how we take photos to make sure that we're able to track our patient's progress, and markings, as well as areas that we want to lipo and areas that we prefer to avoid liposuction on. So with local anesthesia, we call this tumescent anesthesia, and I'm going to show you our tumescent mixture, how we inject it in the most comfortable way for patients to have local anesthesia liposuction in a very comfortable environment, as well as safety considerations with local anesthesia to make sure we're not approaching any kind of local anesthesia toxicity. I'll show you adjunctive medications that are helpful, materials you may need, facility requirements, how we monitor our patients, as well as different anatomic considerations, as I mentioned. In the intraoperative care, we're going to discuss how we drape and position the patient, how we maintain a warm operating environment to reduce bleeding, IV fluid replacement as needed, guidelines for different types of sedation and analgesia, and safety guidelines for acceptable volumes to remove in an in-office setting. Post-operatively, we'll discuss how we monitor the patients, how we use compression, lymphatic massage, how we follow up with them, and different wellness support options. Also, very importantly, we'll discuss potential complications intraoperatively, post-operatively, and how we manage those. So first of all, in plastic surgery, liposuction, as you would imagine, is one of the most common procedures that are performed and desired by patients. Specifically, liposuction under local anesthesia has become extremely popular, primarily because many patients don't want to undergo a general anesthetic for cosmetic purposes or elective purposes. And this has become a very, such a common option, actually. There are public companies that primarily focus on liposuction under local anesthesia with different skin tightening modalities. So really what we want to focus on during this whole course is how we're going to perform liposuction under local anesthesia with different types of skin tightening modalities. The purpose of liposuction is not for weight loss. And that's an important point, because many times patients will come in and they'll ask you, well, how many pounds do you think you can get off? And it's important to emphasize that liposuction is a body shaping modality. We are using suction-assisted liposuction to remove fat from certain undesirable areas. In particular, very popularly, the abdomen and flank areas can be liposuctioned down to improve the overall proportions, for example, the waist to hip ratio, or if patients have adiposity in the medial thighs or in the upper arms. These are areas that we can reshape, but this is not primarily a weight loss modality. This image here shows you essentially what we are trying to achieve. The first liposuction procedures were actually performed by an OBGYN using a large cannula and no tumescent anesthesia. And what happened was it would remove a lot of fat. That suction cannula would remove a lot of fat, and there was no way to really control bleeding, so patients had a significant amount of blood loss. Today, with modern day tumescent anesthesia techniques, we're able to use lidocaine epinephrine mixtures to minimize blood loss, minimize discomfort, even under local anesthesia. And we have more advanced cannulas, which we'll speak about, that can suction out the fat in a very precise way, very efficient way, while leaving a superficial layer of fat to avoid contour deformities. So the goal of liposuction is to remove subcutaneous fat, but in the deep layer primarily, to change proportions of the body shape. So who are not candidates for liposuction? It's very important when we're assessing patients to identify which patients have primarily visceral fat or intra-abdominal fat versus primarily subcutaneous fat. And this can very easily be done with a pinch test. So when you pinch someone's subcutaneous fat, you can get a sense of the thickness. The thickness of your pinch, and I'm going to show you a video here shortly, tells you how much subcutaneous their fat is folded on itself. So for example, if you have a 2-finger breadth skin pinch or subcutaneous pinch, that means there's 1 finger breadth of subcutaneous fat under the skin. So you're folding the skin on itself to get a sense of how much subcutaneous fat is. Now, if you're performing virtual consultations, it's very difficult to tell from a photo what contribution of the person's fullness is visceral fat versus subcutaneous fat. So I find it critical to have a physical examination and assess this. And unfortunately, I've made this mistake in the past. You'll have a patient that has a lot of visceral fat and little subcutaneous fat. And if you try to treat that patient with liposuction, they're going to see very little to no result. And you're more likely to encounter contour deformities because there's a thin layer of subcutaneous fat in these patients. And when you suction that fat, there's just less runway, and you're more likely to have to oversuction certain areas and have a contour deformity. So you really want to assess visceral fat. In patients that have excess visceral fat and not much subcutaneous fat, they are better candidates for a weight loss program, maybe semaglutide, maybe even if they have high BMI, potentially weight loss surgery like a gastric sleeve. But they're not great liposuction candidates. The second thing we're looking for is, what does the skin elasticity look like? So typically when I'll have a patient come in for an assessment, these are the questions I'm asking. I want to know, has their weight been stable, or have they had significant weight loss? Typically, patients who have had massive weight loss, like more than 50 pounds or 100 pounds even, they'll have stretch marks and they'll have loss of skin elasticity. Those patients, their skin elasticity is burnt out. And even if they have subcutaneous fat, what's going to happen is you're going to devolumize the soft tissue envelope and they're going to be left with excess skin. And patients, when they come into you, they just want to look better. They don't know if the primary issue is fat or skin laxity. They depend on you to assess that. So the first thing we do is we ask about any kind of weight fluctuations. The second thing we ask about are pregnancies, number of pregnancies, because similarly, that will stretch and deflate the skin and affect skin elasticity. And there's some other questions I'm going to show you later on. Menopause is important, hormonal changes in terms of skin elasticity. And when we're physically looking at the skin, you see in this image here, we see stretch marks, which are essentially scars on the underside of the dermis. And we want to avoid patients that have a lot of stretch marks because it indicates that there was a stretch and deflation and their skin may not accommodate a volume reduction with liposuction. So our ideal patients for liposuction are patients that have an ample subcutaneous layer of fat, have good skin elasticity, that we know once the volume's removed, the skin is going to adequately contour to the proportions that you've created with the liposuction. Now, sometimes patients can be in the middle ground, and in the second portion of this course, we're going to discuss different radiofrequency technologies that allow energy-based skin tightening for those patients that may be in the middle ground with skin laxity. Realistic expectations are critical. And in my practice, I spend about 45 minutes to an hour not only getting a history and physical from the patient, but I really want to understand, what are their expectations? What do they think this is going to turn out to look like? Are they expecting a tummy tuck type result with just liposuction? Many patients feel that they're going to come in and request liposuction and achieve a result that may be more dramatic than is possible. So identifying which patients you want to operate on is really critical. And I'll tell you, plastic surgeons who are very experienced routinely take 20, 25, 30% of the patients who they see and do not offer them liposuction procedures, because either they're not good candidates or their expectations are higher than what we can realistically achieve. It's much easier to just explain to these patients that they're not candidates or that their expectations are not reasonable upfront. We want to make sure our patients are having healthy lifestyle. It goes without saying that liposuction is a modality to change body proportions, but it's not a modality to improve the patient's lifestyle. So we actually refer our patients to a nutritionist during the pre-op process to ensure that they're having a healthy diet, they're exercising, and they're able to maintain these results. So what are the other important components of the history and physical examination? First, we want to look at any kind of cardiopulmonary risk factors. We want to make sure they don't have sleep apnea. Diabetes is a very important indicator for healing. We do not operate on smokers. It increases the risk for wound healing complications as well as other complications. We do want to know what previous surgeries the patients had, as this may increase risk in terms of scar tissue. For example, patients who have had different hernia operations, they may have mesh in place, they may have a recurrent hernia, patients who have had C-sections, cholecystectomies. We just want to be aware of where the scar tissue may be and if there may be any danger areas in relation to hernias. If the patient does have diabetes, we'd want to know that hemoglobin A1C to ensure that it's well controlled. Part of our screening process is ensuring that the patients not only don't smoke, but also do not use substances. We do want to know what supplements the patients are using. In your packet, there is a document showing which supplements are acceptable to use in the perioperative period and which especially in related to bleeding risk, which supplements need to be stopped 2 weeks before to ensure that you're not increasing the risk of bleeding and bruising. We'd also want to know if they have any kind of implantable devices, for example, a pacemaker, especially if we're using energy-based devices such as radiofrequency. We want to know that we're not doing anything contraindicated in terms of implantable devices. Many times these implantable devices are in the subcutaneous space where we're performing liposuction. The ideal patient is a healthy patient, has realistic goals, non-smoker, rather on the lower end of the BMI spectrum, less than 30. We're going to discuss Caprini score and DVT risk, and a basic set of labs should obviously be within normal limits. We check at least labs on all of our patients because, especially in more high volume liposuction cases, there can be fluid shifts, there can be blood loss, and we'd like to know where that patient is starting out. Many patients, women in particular, can have heavy menstrual cycles and can be anemic without even knowing it. So they can easily have chronic anemia with a low hemoglobin, and you wouldn't otherwise know it before performing a liposuction procedure. So we check those so we have a baseline idea of where the patient's starting from. This is from the American College of Chest Physicians, DVT risk assessment. This is the Caprini score. We're including it in your packet, which is the perioperative packet, the operating room packet that we go through, which is very helpful because it gives you a checklist of everything that you need before going into a procedure, even a local anesthesia procedure. So we'd want to know, I'll show you how we calculate the Caprini score, but we want to know how to treat patients after the Caprini score. Because if the patient, really most of your patients should not be a moderate to high risk. Most of our patients are very low to low risk, and in which case we just recommend early ambulation. Sometimes we send them home with sequential compression devices for mechanical prophylaxis, but we rarely, if ever, will perform a procedure on a patient that would require any kind of Lovenox or heparin postoperatively. So the key elements of the physical examination are a pinch test to see how much subcutaneous fat there is, identification of skin tone and elasticity, and this can be part of the pinch test. If you pinch and pull the skin away a little bit from the patient, you'll get a sense of what the snapback of the skin is, and you'll get a sense of the elasticity that way. We want to be very cautious about identifying hernias in patients. The last thing you'd want to do is have an intra-abdominal injury due to a hernia. So you want to take a look at the abdomen, especially the periumbilical area, to see if there's any type of hernias that are visible. And if there's any question, we normally get imaging, either a CT scan or an ultrasound, to identify hernias. We want to look for cellulite, especially in the thigh areas when we're performing liposuction. Cellulite will typically not improve with liposuction. What a cellulite band is a fibrous band that's holding the dermis down to the underlying fascia. And liposuction will not correct this. And many times patients think that liposuction will correct cellulite. So it's important to identify it, point it out to the patient. We'll discuss zones of adherence, and I'm going to include an article all about zones of adherence. These are areas where there's tight fascial attachments. There's a number of them, especially in the thighs, where we do not want to perform liposuction. You increase your risk of contour deformities and bleeding. We want to look at scars. We want to look at diastasis. Diastasis recti is when the rectus muscle separates, typically with pregnancy, and this can lead to fullness as the intra-abdominal contents are not being held in well. And the only way to correct a diastasis is surgically in the present time. So we want to assess diastasis. You want to discuss that with the patient. Say, even if we reduce your subcutaneous fat significantly, you still have a diastasis from pregnancy and childbirth, and that's going to persist. And it'll give you the illusion of fullness because your intra-abdominal volume is pushing outward. As we discussed, we want to look at visceral or intra-abdominal fat, and you always want to measure height, weight, and calculate the patient's BMI ahead of time. Normally, we see our patients at a pre-op visit 2 weeks before surgery, and during this appointment, we're really going through all the preparation steps for surgery. So we're going to take our photos at this juncture. We're measuring height and weight. We're going through risks and benefits of not only the procedure, but also the anesthesia. And we're going to provide you with those informed consent forms, not just for liposuction, but also for different anesthesia types, local anesthesia, sedation, and also for any kind of energy-based technology which you may add. We're going to go over instructions with the patients, make sure they understand how they're going to manage aftercare. We do have an article that we're including in your packet discussing supplements. Arnica and bromelain can be helpful for bruising and swelling. There's good evidence for that. And we'll also discuss supplements that should not be used around surgery. So on the day of the procedure, we always check pre-procedural vitals. We do a pregnancy test, which is required before any procedure, including local anesthesia procedures. If we suspect the patient's a smoker, we may do a continent test. We recheck height and weight, and retake a set of photos. Photos and height and weight are very important because the patient may end up gaining weight 3 months from now, and you just want to make sure that you have good documentation and good photography to demonstrate the patient's progress throughout the procedure. The last thing you want is a patient coming back after the holidays who's eaten a lot and say, I don't see much of a difference from my liposuction procedure. In fact, I've gained weight. This packet is included with your materials, but it's a great resource for photographic standards. Having standard photography is really key in assessing patients and really giving them a clear idea of where they started from and where they're going in their procedure. So we want to make sure that we have a consistent focal distance depending on the area of the body. So here you can see this comes from the photographic standards. The camera can be moved backwards. Here's where the patient stands. And this shape here demonstrates where their feet go. So what we do is we have on the floor markings to show, okay, your feet are pointing forward, 45 degrees, lateral, or posteriorly, same thing. So we have marks on the floor that indicate how far you want to be for face up, for close-up face, ears, mouth, anything like that, all the way down to full face, to full body, to breast, abdomen area. So we try to keep a consistent focal distance and a consistent patient position. There are imaging softwares that will actually ghost your previous photo on the new photo, so the patient's in the exact same orientation. You can line it up like a stencil on the exact same orientation. So for the abdomen, which is one of the most common areas we're performing liposuction on, we want to get a AP view or a frontal view, and then a 45-degree angle on both sides, and then a lateral angle on both sides. And if we're adding flank liposuction, we want to do the same thing on the posterior side to get a good visualization of the flank area. If we're performing neck liposuction, similar idea. We want to get an AP view, 45, and then lateral. So here you're going to see the markings on a typical patient. This patient you can already see is a very good candidate for liposuction. And you're going to see I'm going to perform a pinch test on her and demonstrate that she has good skin elasticity and primarily subcutaneous fat. So what I'm going to do here is first mark the midline. And then I'm going to mark each semilunar line. So these are the outer borders of the rectus abdominis muscle. And when we perform liposuction, we want to highlight these lines. So what I'm going to do in the actual liposuction procedure is create access points at the base of these lines. So I'm going to create one at the base of each semilunar line. I'm going to create one centrally at the base of this line, linea alba, and then I'm going to create one or two in the umbilicus. And the reason I create my access points there is because I can over liposuction these lines a little bit to create a shadow, which will give kind of a medium definition look. With liposuction, as you become more advanced, it's not all about making the skin envelope totally even in thickness. It's about creating shadows. And a great place to create a shadow are the outer parts of the semilunar line, as well as the linea alba line, because the human eye identifies that as kind of muscular borders. Next, I'm going to just make a topographic map of where the flank is most prominent. In women especially, it's desirable to really reduce the flank volume because that's going to improve our waist to hip ratio. We'd like a waist to hip ratio of about 1:2 or 1:1.5. So the less flank volume there is, the better the waist to hip ratio is typically going to look. So we're identifying this via topographic mapping because once the patient's laying down, it's going to be more difficult to identify exactly where these areas are. So our goal in this case is really to liposuction aggressively the flank area from the anterior and posterior angle. And then we're just identifying other areas of adiposity. Typically, there are two little pockets on either side of the upper abdomen, and then centrally we want to reduce the volume here in the central abdomen. So here you can see I'm performing a skin pinch test, and my pinch here is about 2 finger breaths, so I know there's enough subcutaneous fat where we're going to make a meaningful difference. The other thing you can do is have the patient flex their rectus abdominis muscle and get a sense of how much of a diastasis there may be. So if the patient flexes and everything really sucks in very hard, that means they have more of a diastasis and something you want to be aware of. So I'm finishing the marking on this patient, and then on the posterior side, I'm going to mark my access points. Normally we place them kind of where the venous dimples would be. And then I'm marking out the flank area and also identifying where there may be any bra roll or crease, because we do not want to deepen any kind of creasing area. So we're identifying that and looking for that so we're not liposuctioning in those areas. So you can see how taking this flank fat down is really going to make a meaningful difference. Another thing, as you see, I just did here was I wrote a plus sign because there's more, I see more on the right side than the left. So I just want to remind myself that there's some more there that we can remove. Notice I'm marking above the bra roll fat, so I'm not really deepening that line. I'm going above that line to reduce volume there. We're also going to liposuction kind of the central mid-back. That gives a nicer kind of contour to the lower back. So in terms of facility and equipment, this procedure, liposuction under local anesthesia, can really be performed safely in 2 settings. It can be performed in a full operating room environment. Typically, practitioners prefer, unless you have an operating room in-house, prefer not to perform liposuction under local anesthesia in an operating room environment because you really don't need the general anesthetic, and it can come with significant OR costs. Many times what you can do is take a larger room, convert it into a procedure room, and have all your equipment there and a sterile field for your liposuction under local anesthesia procedure. Now, oftentimes I recommend getting this room accredited. Accreditation, which we'll discuss, can be performed by either triple AHC, quad ASF. It's state specific. So I would look at your state medical board and see what accreditation is acceptable for procedures. And there are different levels of accreditation. So you can be accredited for local anesthesia or for sedation or for general anesthesia. And I think having accreditation can be very helpful because if you have accreditation and there's any kind of complication or any kind of issue that may come up, it's, I think, very beneficial to say this was performed in a triple AHC accredited room for local anesthesia. We followed all their guidelines. We abide by all their standards. And I look at it as some people view accreditation as a hassle. I view it as a safety mechanism to ensure that you're doing everything per standard. It keeps you safe. It keeps you organized. So I actually think accreditation is an important thing to keep everything above board. Based on the accreditation, you can really look at, and we'll give you our accreditation paperwork in terms of what our operating room paperwork looks like, what our checklists look like. So even if you don't attain accreditation, which you don't have to, you can at least follow those guidelines. Part of those guidelines include staff. What kind of staff do you need? Typically, we have a person who is a scrub, as well as a person circulating. Both of these, the scrub, depending on the state, needs to be a certified scrub. Some states that's not required; they can just have scrub experience. But you want to make sure they understand sterile technique, they understand how to sterilize instruments appropriately. And then your circulator is typically an RN, but can be, at least in Nevada, can be anybody that has BLS, basic life support, credentials. You want to make sure you have a comfortable OR table or a stretcher or an exam chair that can flatten comfortably to allow for the patient to lay down or be repositioned. One of the things I highly recommend is monitoring. I think it makes a lot of sense to monitor the patient during the procedure. And so you know where their vital signs are, you know if they're having a vasovagal response, you know if there's any issue with oxygenation or any kind of cardiac issue. So I would highly recommend getting a patient monitor, and I would recommend finding one that automatically will print your vital signs. So in our case, we plug our patient in, we have EKG, blood pressure, pulse ox. It's recording throughout the procedure. And then at the end of the procedure, we press a button, the whole thing prints, and it's included in the medical record. So then we have a pre-op set of vitals, intra-op throughout the procedure, and then we check post-op vitals as well. Part of the value of accreditation is it really spells out what you need in your crash cart. And I will send you in your packet a list of everything we have in our crash cart, including the quantities. But for liposuction under local anesthesia, there's a couple things you want to ensure you have. Intralipid, which we'll discuss, is a formulation which is the only way to reverse local anesthesia toxicity. So if you have a patient and you've injected too much local anesthesia by accident, and you're sensing that they may have a local anesthesia toxicity, they need to have an IV and they need to run intralipid, and I'll show you the volumes. So intralipid will bind to the local anesthetic, and it's the only way to reverse a local anesthesia toxicity. So having intralipid is critical if you're going to do any kind of procedure under local anesthesia. Of course, you're going to want to have an AED, basic crash cart meds, an airway, ambu bag. And performing drills is important with your whole staff, so they understand in the event of a cardiac event, for example, everybody knows their role and everybody knows who they would call and what they would do in that scenario. So let's discuss local anesthesia and tumescent technique and how we perform that. Really, the amount of tumescent you use is critical to safety. So typically, when I'm performing a local anesthesia procedure in the face or in the body, we want to keep our concentration at 35 milligrams per kilogram or less. Now, in the dermatology literature, they've performed liposuction up to 50, 60, 70 milligrams per kilogram of local anesthetic, but we want to be well beneath that safety guideline. You never want to create a problem. Rather have the patient have slight discomfort rather than approach a local anesthesia toxicity, in my opinion. So our mixture for tumescent typically has about 50 cc's of 1% lidocaine with epinephrine in a 1 liter bag. Now, this can be adjusted based on how much liposuction you're doing, how much tumescent you need. Typically, we're injecting tumescent at about a 3-to-1 ratio, meaning we're injecting 3 of tumescent for 1 of aspirate. So if you're planning on obtaining 1 liter of lipoaspirate from the suction, you're going to want to inject 3 liters of tumescent. So in the smaller cases where you're not injecting a lot of tumescent, and if the patient, if their weight is appropriate, we'll show you how to calculate this, you can inject a slightly higher concentration of lidocaine in the tumescent, up to 100 cc's of 1% lidocaine with epi per liter. So that would be 1 gram per liter. But typically for our standard lipo case, we like to do about 50 cc's of 1% lidocaine with epinephrine. And that epi is 1 to 100,000. Now, sometimes if you're concerned about bleeding, you can add epinephrine, an amp of epinephrine to that bag. Many surgeons do that to minimize bruising and bleeding. Similarly, sometimes they add tranexamic acid to the bag to minimize bleeding. Tranexamic acid is an antifibrinolytic. So at the end of the coagulation cascade, it stabilizes clot. Doesn't create clot, but it stabilizes clot. and it's increased in popularity in plastic surgery quite a bit over the past 5 to 10 years. And sometimes providers will add bicarb to minimize any kind of burning from the lidocaine. So calculating lidocaine limits. So first, we want to look at different types of wetting solutions and associated blood loss. So if you did a procedure, a liposuction under awake, essentially without any tumescent, you're going to have a substantial amount of bleeding because there's no epinephrine in the mix and the blood vessels are not constricted. So nobody really performs liposuction without any infiltration. In fact, very few people even perform wet technique, which is like a 1 to 1.5 ratio of infiltrate to aspirate. Most plastic surgeons today perform what we call the tumescent technique. And what that means is you're basically filling the soft tissue with the tumescent infiltrate until the skin looks full. And then basically we're obtaining a 3-to-1 ratio, which minimizes the risk of bleeding. Now, even though this procedure, and I've performed it many times under just local anesthesia, no analgesia, no amnesia medications, it's helpful to have some type of analgesia or amnesia on board just to make the patient's experience more comfortable. So these are some of the items that we use in combination to improve patient comfort during the local anesthesia procedure. So Pronox is a great method. It's a self-administered nitrous gas mixed with oxygen, and the patient essentially breathes it in themselves. It's used very often in med spas. It has a quick on, quick off effect. It's good because it distracts patients. It functions as an analgesic, and it makes the procedure a little more comfortable. Many providers will use diazepam for the amnesia effect, midazolam, ketamine, ondansetron tabs, which are basically like Jolly Ranchers. Disuvia or sufentanil, which is sublingual fentanyl, has increased in popularity quite a bit for its safety profile and an excellent analgesia. Patients who take Disuvia are typically unbothered by a procedure, even if it's a little bit uncomfortable. And sometimes narcotics are added to the mix as well. So I want to show you how we perform local anesthesia step by step, so you can really understand what the best practices are to numb the patient with minimal pain. And I think the local anesthesia portion of this is really critical, because if the patient starts to feel discomfort, it will make them tense and it will make them more sensitive to discomfort later in the procedure. So really getting this right is key. Here you can see the soft tissue envelope. You have your skin, you have your subcutaneous fat. Here's the deep fascia and the muscle. So this is applicable to any place in the body: neck, abdomen, flanks, thighs, arms. And typically what we'll do, there's a couple ways to do this. The first thing I would suggest is, while the patient's in the pre-op area, it's nice to just create your marks, create where you want to have your access point, and then just put a little bit of topical numbing on that area. I think even for the patient psychologically, they like to know that there's some topical numbing there. Let it sit for half an hour while you're getting the patient ready. Then what we're going to do is take a 10 cc syringe with 1% lidocaine with epinephrine, and we're going to inject that right in the subcutaneous space. So an important point here is, do not inject the local anesthesia in the dermis. You don't want to create a wheal. You don't even want to see any skin changes from your initial local anesthetic. So inject the 10 cc of 1% lidocaine with epi directly in the subcutaneous space. Oftentimes I'll just go straight perpendicular under the skin into the subcutaneous space. So each access point can get anywhere from 3 to 5 to 7 cc's of 1% lidocaine with epi. Now keep in mind, you're above the superficial fascia system while you're performing this for now. Next, what we do is we take an 18 gauge needle on a 60 cc syringe with some tumescent fluid, and then we start in the same direction, same depth, injecting tumescent. And what we want to do is inject tumescent here, followed by a tumescent cannula. So what a tumescent cannula is a blunt cannula with many small holes in it that will move through the subcutaneous tissue and inject tumescent fluid in all directions. So the goal here, actually, once we've created an access point of numbness with our 1% lidocaine with epi followed by our tumescent, is to come in with our tumescent cannula and start injecting in the deep space. So you want to actually numb the subcutaneous tissue deep to superficial. The nerves, you can think of them like a tree, and all the branches are by the skin. The skin is far more sensitive than the subcutaneous tissue. So if you're able to numb those trees at the root or at the right above deep fascia layer, you're able to move the local anesthetic from deep to superficial. So what's going to happen is after you've numbed with the 1% lidocaine with epi and then the tumescent, you're going to come in with a tumescent cannula. You're going to hear a small pop, in this, meaning you've gone through the superficial fascia system or the scarpus fascia, and then you can start injecting right above the deep fascia. This is a natural plane, and you'll feel when you inject your tumescent, it's a very easy place to inject. So the tumescent will just flow very freely because there's very little resistance in that area. And then once you've filled the deep layer, you can start to move more superficially to inject local anesthetic and tumescent into the area above scarpus fascia. So that's really the optimal way to numb subcutaneous tissue. At the end of all this, you can test your efficacy of local anesthetic by passing the tumescent cannula in the subcutaneous tissue under the skin to ensure that the patient's numb completely. Some people like to use a spinal needle, which is smaller than a tumescent cannula, to inject the tumescent. I think that's totally fine and works well and may even be a little more comfortable. But the benefit of the tumescent cannula is that it's blunt. And so one of the key safety features is you certainly want to avoid the deep fascia. So with a tumescent cannula that's blunt, it's effectively impossible to pass through the deep fascia. So as opposed to a spinal needle, which is sometimes sharp, it can pass through fascia more easily. So I prefer the tumescent cannula. It's blunt at the tip. You see all the holes here, spreading the tumescent very evenly through the subcutaneous space. Now, liposuction cannulas, there's a plethora of different liposuction cannulas. You're going to have a list in your packet that demonstrates what materials you should have to start. Normally, we recommend purchasing a 3mm, 4mm, and 5mm cannula. It's good to have what we call a basket cannula because we like to use the basket to equilibrate the soft tissue. So there's a concept in liposuction called safe liposuction. What that means is you inject the local anesthesia, just like I showed you, and then we're going to use a basket cannula off suction to spread and kind of dislodge the fat, ensure that the local anesthetic is well distributed. So we just pass the basket cannula to kind of spread and disrupt the fat cells off suction. Then you would aspirate. You can either use a tip like this, which is considered to be an accelerated tip because of all the holes, or a Mercedes tip, which is a little bit less aggressive. Usually we would use a 3 or 4mm cannula, depending on the patient, to aspirate. And then after that, we'd come back in with a basket cannula to equilibrate the fat. So again, off suction, we would pass the basket cannula to kind of spread the fat that's there and make sure that everything is equal. So separation, aspiration, fat equalization is the SAFE acronym. Now, when we inject the tumescent, depending on the patient, you can either inject it on a tumescent cannula that luer locks onto a 60 cc syringe and just with your scrub tech, just kind of pass syringes. I like that technique because it gives you more control. In larger cases where you really don't have the time to do that, you can use one of these tumescent infiltration pumps. So what this is essentially is a roller pump that's going to, at variable speeds, push tumescent through your tumescent cannula, and it's foot pedal operated. So you can adjust how fast it comes in, and this way you don't need to exchange syringes. You can just have a bag sitting with tubing that goes directly to your tumescent cannula to roller pump in the tumescent fluid. So here you're going to see my tumescent technique. This is how I prefer to inject tumescent fluid, and I'm going to show you some of the considerations here. So you always want to know where your cannula is. So I have a 60 cc syringe here, and I have tumescent fluid here, and this is my tumescent cannula. Now notice my left hand is feeling where my tumescent cannula is, where the tip is, and my depth is rather deep. So here again, this is the patient's abdomen that we just marked out. These are our access points. Now these white skin protectors are because we're going to use an energy-based liposuction modality, so we're protecting the skin. But if you're not using energy-based liposuction modalities, you just take a little 15 blade and create a 2 millimeter incision, 2 to 3 millimeter incision. So here in this video, my tumescent fluid is here. I feel where my tip of the cannula is. The patient's awake. She's been prepped. All the drapes are sterile around her. And I'm injecting. Now the fluid is flowing very easily. I can feel where I'm injecting, and then I advance. So I inject first, and then I advance after that. So I'm right above the deep fascia, and I'm injecting row by row to ensure that I have adequate tumescent in a 3-to-1 ratio of what I plan to aspirate. Now, if you hit the deep fascia, one of the benefits of local anesthesia is that the patient's going to tell you, so you'll know, you'll get feedback from the patient in terms of how deep you are, whether you're too deep or not. So that's actually beneficial over a general anesthetic where you're not able to get that feedback. So again, I'm going row by row. I'm injecting the tumescent. It's flowing easily, and I can feel where my tip of the blunt cannula is in the subcutaneous space. Now, as far as once we inject tumescent, we're going to wait about 5-10 minutes for the epinephrine to take effect, and then we're going to actually perform the aspiration portion of this procedure. So my preferred, there's many different pumps you can use. It's basically just a vacuum pump. My preferred device is called the Wells-Johnson Hercules. It has 3 motors on it, and here we have our setup. So what you'll have here is a canister, which is attached to your vacuum pump. And then there's another attachment here that's going to attach to our actual tubing for the liposuction. So essentially this device creates a vacuum in this canister, and that suction is going to translate to the tubing and the aspiration cannula. There are different ways to aspirate fat. I would suggest when you're starting to just use standard suction-assisted liposuction cannulas. As you do more and as you become more advanced, there are power-assisted options. This is what most plastic surgeons use, which is the micro-air system. The micro-air system essentially is a liposuction cannula that vibrates, and it vibrates in order to dislodge the fat. Essentially, it makes liposuction more easy for the user and a little more comfortable for the patient. The vibration kind of distracts the patient as well. So oftentimes here you can see we have skin, fat, and muscle. The local is the blue, all the tumescent that's within the tissue. So we're using the SAFE technique again. So we injected the tumescent, then we come in with a basket cannula in order to separate the fat. Then we aspirate, so SA, aspirate, and then we come in again with the basket cannula off suction to fat equalize, make sure that everything looks even. Now, what this is showing you is we're going to use energy-based technology, and I'll show you this in the second portion. This is ultrasound lipo, where you can use ultrasound waves to break through the liposuction fat and then suck it out. Now, our main interest, which this animation doesn't show very well, is really to liposculpture the fat in the deep layer of the subcutaneous tissue, so sort of the second half. If you suction too close to the skin, you're more likely to have contour deformities, and you want a small layer of skin there, a small layer of subcutaneous tissue there to make everything look even. So our real goal is to suction the deeper fat layer. So this is an ultrasound-assisted liposuction machine. That's why we're using the ports. And when we're performing liposuction, there's 2 ways I like to do it. One way, so we're going to go in. One way is to feel. It's very important. Liposuction is a very feel-dependent technique. So it's very important to feel with your left hand where the cannula is, what your skin thickness is. And there's 2 ways I like to do that. One way is you hold the subcutaneous tissue up like a hot dog almost, and you're suctioning around the borders of that. And then you can pinch with your left hand to get a sense of what that subcutaneous tissue is like. Another way to do it is to hold your hand on the skin like a flat plate and then liposuction underneath so you can feel what the skin thickness is and where your cannula is. So that there's different ways to do that, but you want to constantly be assessing where your cannula is and what the skin thickness is, what the soft tissue thickness is in those areas to ensure that you're creating an even liposuction plane. So intraoperative considerations, we always give preoperative antibiotics. We want to ensure that the patient, this procedure has a very low incidence of infection to begin with, but we want to minimize it as much as possible. So typically, if the patient has an IV, we'll give them Ancef 1 to 2 grams prior to any incision. If they don't have an IV, we'll give them either Bactrim or Keflex or Clinda. Like we discussed for sedation, this is the Pronox device, so it's self-administered. The patient holds this to their mouth, takes a deep breath in. Sometimes their voice will deepen. So they're getting 50% nitrous and oxygen, self-administered. Many times orally, we'll give the patient some Valium or some narcotics to just kind of function to calm them and to decrease any kind of pain. We want to look at ASA classifications. So we want all our patients to really be an ASA 1 or maybe 2. Any patient that's higher than that, 3 or 4, you really don't want to be performing liposuction on. So we want to have patients that are generally very healthy as part of their pre-op considerations. Heating the patient is very important. So we want to make sure that the patient's warm, primarily to minimize bleeding and maintain homeostasis. So you can do that either with warming blankets, or you can do it with a bear hugger, or there's also a pad called the hot dog, which you place under the patient to warm them. But maintaining, you have to consider the patient's going to be potentially in a cold room without much clothing, and you're injecting rather cold tumescent solution into the subcutaneous tissue. So ensuring that the patient is warm is important, not only for their comfort, but also for their homeostasis. Some providers will also warm the tumescent fluid in a fluid warmer so that you're not injecting kind of room temperature fluid into the patient. Positioning is very important in order to maintain, first of all, to ensure that you're providing adequate liposuction. You really want to make sure you can move the patient. So for example, and that's one of the benefits of local anesthesia, is the ability to have the patient help you move so you can reach the areas you need to in the most effective way. So typically what we'll do is we'll start with the patient in the supine position and liposuction the anterior abdomen and flank areas, and then we'll move them into a decubitus position to really address the posterior flank and bra roll area. And that can be addressed either moving from inferior to superior with the cannula, or some providers prefer to make an access point above the ribs and move down into the flank, so that's variable. But in any case, it's important to position the patient, make sure their arm is extended, so you're able to access the flank fat specifically in a very effective way. This is an illustration of different access points. So for example, if we're going to treat the anterior abdomen, normally what I'll do is create an access point at the base of each semilunar line, one in the midline, 1 or 2 in the belly button. This allows us to crosshatch, which is an important consideration with liposuction. You want to liposuction in one direction and then take another access point and liposuction in a perpendicular direction to ensure that you're reaching your skin thickness goals in 2 directions to minimize contour deformities. For the medial thigh, we typically make an access point by the medial knee, and that allows us access to the medial thigh. You can combine this with a second access point in the upper thigh, so you're able to crosshatch and minimize any kind of contour deformity. And like I said, for the back area, you can make an access point at the superior buttock or at the upper rib area. So you can either liposuction inferiorly or superiorly. Same thing for the posterior flank. You can make an access point at the medial knee or at the inferior buttock and address the thigh area. For the arms, we typically like to make an access point at the just proximal to the elbow, about 2 finger breadths, so you're avoiding the ulnar nerve, which is superficial there, and then you can liposuction the arm almost 270 degrees using that one access point. So in terms of the anatomy of soft tissue, we have our liposuction cannula here. We have our superficial fat and the deep fat. And as I mentioned, we really want to try to avoid suctioning too much of the superficial fat unless you're performing high definition liposuction or etching, where you're creating an intentional contour deformity at the skin layer. So otherwise, what we want to do is remove the fat specifically in the deep layer, which will ultimately make the soft tissue envelope thinner in those areas. But you really want to leave the superficial fat to allow for a smooth result. There's an article in your packet all about zones of adherence, but this is an illustration from that article. So zones of adherence are kind of fascial attachments that we prefer to avoid, not only for the risk of contour deformities, but also minimize bleeding. So many of these zones of adherence focus around the thighs and buttock area. So one of them is lateral gluteal depression, distal posterior thigh, mid-medial thigh. So these are areas that you just want to avoid liposuction. They're typically pretty tethered to the underlying fascia, and there's typically not much gain to liposuction in those areas. So you can imagine this kind of patient, they're going to want the flank liposuctioned. They're going to want the what we call saddlebags or lateral thigh liposuction, but those don't involve any areas of adhesion. Lower abdomen is fine, anterior thigh is fine. So with cellulite, this is what cellulite looks like. It's a little bit difficult for the beginner to identify the difference between cellulite and skin laxity. Cellulite is this dimpling, which is basically a fibrous attachment of the skin to the deep fascia. And liposuction will not improve this. So many times patients will come in with exactly this appearance, and they think that this is primarily fat, and they think that liposuction is going to improve this cobblestoning appearance. But if anything, it may certainly may not improve it, may even make it look more prominent. So that's an important thing to identify cellulite in these patients. And there are other treatments for cellulite, but liposuction is not one of them. There are devices that have come out, such as the Avali device, which will hook the bands and subsize the bands. But even these devices haven't shown too much improvement in cellulite that we've seen. So here again, I'm going to show you liposuction technique. So this is a regular suction-assisted cannula. And here's this hot dog method I described. So what we're going to do is kind of hot dog the skin up, and then I'm liposuctioning in a U shape, and it allows me to also pinch and assess how thick my skin envelope is. So I'm taking long strokes. I'm identifying, I know where the actual hole is on my cannula, so I know where the suction is actually happening. And my left hand is critical to feel how thick the skin envelope is there, where I want to suction more, where it's thicker, and where I want to avoid suctioning, where I've already suctioned. So we do a skin pinch after and see where the area of adiposity is, where we want to treat. See if there's any area where we over-suctioned, where there may be a contour issue. And in those cases, either you liposuction more around those areas, or you can take some fat and equalize it by either injecting it or just shifting it over to fill those areas. Here's another example on the flank area. So here, the liposuction cannula I'm using to empty out the flank. I'm feeling my skin pinch on the left hand, really getting a sense of how thick I am. Now in the flank, I really want to empty it out, so I'm being a little more aggressive by going more superficially. And I'm feeling exactly how thick my skin envelope is. Now here, I'm using a flat technique. So my hand is flat on the skin. I can feel where the cannula is underneath. I can feel my skin thickness. And I'm bringing the fat actually closer to the cannula by pushing it in. So what I'm doing is I'm pushing the soft tissue into the cannula and allowing the cannula to do the work, and I'm fanning in order to remove the fat from the whole flank area using long strokes. I'm trying not to stay in the same position too many strokes. I'm fanning to equally remove fat from that flank area. So these access points are typically about 2 millimeters. Some surgeons like to leave them open to drain. I prefer to place a single suture right in the middle. And there's going to be a fair amount of tumescent that's going to drain out. But I feel that if you put one suture in the middle, it'll allow the tumescent to drain, and the patient doesn't get stressed that there's open incision. So we just place one simple suture, either a nylon or sometimes just a fast gut, centrally to allow for some drainage of the tumescent, which is favorable. So post-operatively, we want to discuss dressings, garments, as well as drains. I typically don't use drains unless it's a really high volume liposuction case. But for compression garments, there's two phases of compression. There's what we call phase 1 and phase 2, or stage 1 and stage 2. In stage one, ideally you want a little bit of a lower compression so you're not suffocating the subdermal lymphatic channels. And you want that for about a month and a half. And then that can be followed by stage two or higher compression. And if you look at different garment companies like Marina, they'll tell you this is a phase one garment, this is a phase two. Alternatively, and oftentimes what we'll do is use a 3 or 4 panel white abdominal binder that's adjustable for 6 weeks. So there's different ways to do compression. Lymphatic massage, I'm going to show you 2 videos from our lymphatic therapist, who's a certified lymphatic therapist. You can share this with your patients. But lymphatic massage is very helpful to minimize swelling, move the lymphatic fluid to the lymph node basins. And patients, we give each patient a free lymphatic massage so that they can learn how to do it at home. It's a very gentle technique to push fluid out and improve their swelling more quickly. As I mentioned, I typically don't use drains unless it's a really high volume case and there's a fair amount of dead space to minimize seromas. I think unless it's a 4 or 5+ liter case, there's really not much need for drains. I think compression is sufficient. So, but some surgeons prefer to use a JP drain, where this is placed through the incision, or a Penrose drain just to keep the area open and draining. A lot of times, if you do an early lymphatic massage, you can reduce the need for this and reduce the need for any kind of drainage by just pushing that fluid out and then compressing. So in terms of our follow-up schedule, I like to see the patients the next day. The purpose for this is to ensure that there's no hematoma, to ensure that they're walking and they're not, frozen in bed at home where they're going to be at increased risk for DVTs. Also, if we performed an energy-based technology to make sure there are no skin changes that would indicate that there may be a burn, then once that's fine, we'll see the patient a week later, about a month and a half later, 2 months later, 6 months later, and a year later. And it's excellent to get photos at all these appointments, and if you can get weights at all these appointments. Usually at the 1 week mark, they'll actually gain weight from swelling. So I wouldn't be too worried about that, but you really want to start assessing your results at the 2 month, 6 month mark, and maybe a year mark. I'm going to give you a whole article on supplements and nutrition that you can provide your patients for postoperative wellness support. And as I mentioned, lymphatic massage is very helpful for patients. Now we'll talk about something unpleasant, which is complications, which fortunately are very rare with these cases. Major complications are extremely rare. Mortality rate is extremely low. I would argue that liposuction under local anesthesia is actually much safer because you're getting that patient feedback. So if your cannula had a misadventure towards the deep fascia, your patient's going to notify you before it becomes a problem. Any kind of major complication will increase, of course, as the patient's BMI increases, which means your volume of aspirate increases, which means you're typically going to be performing more areas. So you really want to start with an ideal patient, a lower BMI patient without that much volume to aspirate, just to get comfortable with the procedure. So as I mentioned, anybody, older patients, higher BMI patients, as you would imagine, with higher volumes of aspirate in multiple areas are at increased risk. Intraoperative complications, are pretty rare. Visceral perforations, I've never seen, I've never had happen. Less likely with local, as I mentioned, because you're getting feedback from the patient. But they can happen, especially if the patient has a hernia and you're unaware of it and you're liposuctioning a hernia that may contain bowel. Typically, hernias are fat containing, but they can contain bowel. Lidocaine toxicity, we'll discuss that, but you really want to ensure that you're under the limits for local. You want to make sure that that's documented. You'll see in our intraoperative paperwork you're provided, it says specifically what was your concentration of lidocaine, how much did you infiltrate, how much did you aspirate. You certainly want to make sure the patient's not over-sedated where you may have an airway issue. So the patient, remember, this can be done completely awake under strictly local anesthesia. So you're not looking for deep sedation on these patients or uncontrolled sedation. You just want to take the edge off. And the other thing is you always want to assess your aspirate. Make sure that it looks yellowish. You don't want to be sucking out, frankly, bloody fluid. So if you give your tumescent enough time to allow the epinephrine to constrict the blood vessels, your aspirate should look kind of like applesauce, maybe with a little blood tinge, but it certainly shouldn't be frankly bloody. And if it is, you should just stop the procedure and either move to another area or inject more local anesthesia or just abort the procedure altogether if all you're getting is bloody aspirate. So if there's an intra-abdominal injury, it should be obvious to you, especially In the setting of a local anesthesia procedure, the patient will have severe abdominal pain. They're going to have guarding or rebound pain. Rebound pain means you push on the abdomen, you let go, and it hurts more when you let go versus pushing down. The best thing to do if you have any concern about this is transfer your patient to a higher level of care. That's the safest thing to do. And this way they can appropriately be treated with a scan or maybe an exploratory laparotomy if needed. Check your aspirate, make sure that it's not green or bilious or there's any kind of indication of fecal matter in the aspirate. So you'll be able to tell based on the patient's comfort and what the aspirate looks like if there's a problem, as well as their vital signs. I mean, if they're having episodes of hypotension, it's another indication to transfer. This is a little chart that shows you lidocaine toxicity symptoms. So there's neurologic as well as cardiac symptoms. Typically, if the patient has had too much lidocaine, they're going to start feeling numbness, perioral numbness around the tongue, around the mouth. They may have some visual changes. They may have some ringing in the ears. That can lead to seizures, and then ultimately it can lead to unfortunate cardiac arrest or respiratory arrest. You certainly don't want to, if you get any indication of early lidocaine toxicity, it's intralipid and a call to transfer the patient. Here's another acronym for lidocaine toxicity. So numbness around the tongue or lips, which would lead to slurred or difficult speech. Nervous system, either restlessness, ringing in the ears, dizziness, drowsiness, and then it gets to muscle twitching, and then it can get to seizures, respiratory cardiac arrest. So the first thing you want to do is call for help. I mean, I can't emphasize this enough. I think the only way you can really be criticized is by not calling for help soon enough. So don't underestimate that if you start with these ringing in the ears or oral tingling, that can definitely progress to more severe cardiorespiratory complications. So you definitely want to call for help first and then get the code card and inject intralipid. You want to ventilate with 100% oxygen. You should have a little portable oxygen tank available in the room. One of the benefits of using benzodiazepines like diazepam as a sedative for the procedure is it'll increase the seizure threshold, and you want to avoid propofol because it can lead to cardiovascular instability. Avoid any kind of calcium channel blockers, beta blockers, more local anesthetic. And then this shows you the dosages for intralipid. In reality, if this became a problem, you would just put an IV and run the intralipid continuously. I don't think you can overdo intralipid, and by the time you're injecting intralipid, you've already called for help. So they should be there shortly. So I would just run the intralipid wide open, and it's a 20% lipid emulsion mix that you can get from your distributor. More on postoperative complications. More common things are contour irregularities, which you can avoid by staying deep in the fat layer and cross-hatching in a perpendicular fashion so that you're addressing the fat in two directions. Protracted swelling can happen for a couple months after the procedure. Paresthesias, numbness can happen. Infections like cellulitis, seromas, hematomas, or DVTs. So contour irregularities are not uncommon. Usually it's from aspirating with too big of a cannula and too superficial of a plane. So I would recommend in the beginning, use a 3mm Mercedes tip cannula that's more delicate, cross-hatch, stay in a deeper fat plane, and just generally be less aggressive. Using that basket cannula and safe technique I talked about is very helpful to equalize, redistribute the fat. If you have a contour irregularity that's severe, you can aspirate a little bit of fat into a 10 cc syringe and fat transfer to that area. So suck it out and then re-inject it, or even using some kind of filler materials like Sculptra or Radiesse. Prolonged swelling indicates a damage to the subdermal lymphatics. That's part of the reason we don't like to use super hard compression in the beginning. We like to use phase 1 first. But ultimately, time, lymphatic massage, the correct compression garments will decrease the risk of prolonged swelling. Numbness is common. It'll typically resolves over time, and there's really not much to do about it. So you can just tell the patients, listen, this will take some time. It can take 6 months, can take a year. It may be longer with energy-based devices that can cause more injury to the superficial cutaneous nerves, but typically self-resolves because it's just a neuropraxia, not an actual cutting of nerves. Cellulitis is very rare, but you do want to be aggressive about it. It's usually gram-positive bacteria. You know, depending on the patient, if it's a nurse or somebody in a healthcare environment, you may want to cover MRSA. You can use Bactrim, you can use Cipro. If you feel like there may be an abscess underneath, which would be exceedingly rare, it may require an IND and packing. But again, this is very uncommon. As long as your area is appropriately prepped and your cannulas are clean, it really shouldn't happen. Seromas happen because you remove fat and then there's a dead space between the skin and the fascia. The more liposuction you do, the more likely this is to happen. And energy-based devices can actually increase the risk of seroma, like ultrasound liposuction can increase the risk of seroma. You want to use compression. You want to, like I said, use one suture for the access site to allow it to drain. And then if there's a real risk for seromas with a lot of liposuction, you can use a Penrose drain or a JP drain to adequately drain the areas. Typically, if we find that there's a seroma, you're going to touch the abdomen, you're going to feel kind of a ballottement of fluid, and you can aspirate it with an 18-gauge needle on a 60 cc syringe, put a pressure dressing on. If it continues to come back after 3, 4, 5 aspiration attempts, you can place a small seromacath drain and then compress it and then just limit the patient's activity. Shearing forces can add to seroma, so you don't want them to do anything that'll cause a repetitive shearing force, like, for example, running on an elliptical machine or anything like that, or long walks, power walks. Hematomas are usually venous. They're usually not arterial. You know, using blunt cannulas, using tranexamic acid to stabilize clot, of course, adding epinephrine to the tumescent mix. Usually, we don't do much about it. We'll just give it some time, compress it, massage it, and let it resolve on its own. DVTs, we talked about calculating the Caprini score to assess the patient's risk for DVTs. Part of the reason we bring them back the next day after the procedure is to make sure that they're walking, mitigate the risk of deep venous thromboses. It's a higher risk for patients that have a higher BMI, who are smokers, who are higher volume cases, combination cases, who are older. So you just want to make sure that they're walking, check in on them, make sure that they're ambulating as much as possible at home. In some cases, if they have a higher Caprini score, we're worried about it. We'll send them home with some sequential compression devices. And like I said, we very rarely give them anticoagulation after the procedure. So the next portion of this talk is really going to speak to energy-based devices, specifically radiofrequency, and how we obtain ideal soft tissue contraction in the setting of liposuction.
So I'm excited to share the second portion of this course with you, which deals with energy-based technologies that we use oftentimes in conjunction with liposuction to offer us some more skin tightening and better contour overall, both in the face area and also in the body area. So I'm going to tell you a little bit about radiofrequency technology, which we use almost on every liposuction case in my practice, how it works, how we can use it, some of the anatomic and safety considerations, and then I'm going to show you some cases of the face and body areas. I got involved in energy-based technologies early on when I was in my training at Mass General Hospital, where I met Dr. Spiro Theodorou, who's the chief medical officer of one of the leading radiofrequency device companies, InMode, and his partner, Dr. Christopher Chia. We've worked on many of the emerging technologies and publications of it, and this is our book on liposuction and emerging technologies in the face and body areas. So I think both for liposuction and for energy-based technology, the minimally invasive spectrum, local anesthesia is of very high interest to patients, minimizing downtime. Technology is important to patients too. Patients want to make sure that their providers are using the latest technology to provide them with minimal recovery, minimal downtime, and maximal results. So really what we're looking at, and this is the case for both liposuction and also for energy-based skin tightening devices, is who the patient population is. And it basically is the middle group. Those are patients in their 30s, 40s, 50s who desire improvement of their contour of the face, neck, or body area, as well as soft tissue contraction. So this treatment gap group, as we call it, is usually a younger demographic. They desire some soft tissue tightening. They don't want traditional scars. They don't necessarily want excisional procedures. But some of these patients are not severe enough for an excisional procedure, but they may not be mild enough to rely on liposuction with soft tissue contraction on its own. So oftentimes we have a patient that may be borderline for liposuction. We're not quite sure how their soft tissue is going to contract, and that's where some of these energy-based technologies are very useful. The middle group is of high interest to industry because these patients care a lot about how they look. They're willing to spend money on it. The problem is most of the technologies in this space are not very good. So there's cryotherapy, there's chemical like deoxycholic acid or Kybella to melt fat, and then ultrasound as well. So it's really important to pick technology that's going to work reliably and safely. So if you looked at different technologies, we're really focused on what's going to work in order to contract soft tissues. So when we look at different technologies, we're looking at what's going to reliably work in a safe fashion to improve soft tissue contraction. And radiofrequency has really emerged as one of the leading technologies. It's a very familiar technology. It's existed for almost 100 years in different forms. It's entered the aesthetic space in the last 25 years or so. And what's nice about it is it's non-specific. So you can apply this technology to any Fitzpatrick type. And all it is an electrical current that travels through tissue. And through Ohm's law, certain tissue types are going to generate heat based on their impedance. So for example, if you look at the cross-section of skin, fat and collagen is going to generate more heat preferentially when you pass an electrical current. So there's different ways radiofrequency can be delivered. There's monopolar, which means you deliver the energy, and then there's a grounding pad remotely that's grounding this electrical current. There's bipolar, which is what my preference is in our practice, where you have a positive and negative electrode near each other, and the energy is moving between the two. And then there's multipolar as well. So monopolar, most devices are monopolar. J-Plasma by Renuvion is a good example. And then the bipolar devices are the InMode devices, FaceTight, BodyTight, Morpheus, those technologies. So the way this technology works is we're heating tissue, and it works in two mechanisms. The major mechanism is this heat injury is triggering a inflammatory and proliferative cascade. It works through vascular endothelial growth factor and heat injury proteins, which ultimately, basically you're fooling the body into thinking it got burned without burning it. And so you end up getting neocollagenesis, new elastin reorganization and formation, neoangiogenesis, lymphangiogenesis. So it's very regenerative in fashion. And the heat also will cleave hydrogen bonds in the collagen helix and cause some immediate soft tissue contraction. But we always tell patients that majority of the contraction takes about 6 to 8 weeks to begin seeing, because that's the process of the inflammatory and proliferative cascade. So this is an example of a BodyTite device on the underside of a skin flap. And you can see if you measure the area between the before and after, it's about a 30 to 40% contraction of the soft tissue. So the nice thing about these technologies is we're able to use them head to toe in all Fitzpatrick's types. So we use them on the face and neck area, body area. There's also technologies that we'll use for pelvic floor and labia. So I want to kind of walk through different areas with you, what our considerations are, and how we treat these patients. These are the devices that we prefer to use for the face and neck area. So we have the FaceTite, the AccuTite. These are bipolar devices, so the energy is moving from the internal electrode to the external electrode. This is pretty minimal in terms of access, so there's a small 1 or 2 millimeter access point. This internal cannula goes deep under the subcutaneous tissue, and the electrical current is moving from the internal electrode to the external electrode. There's a temperature sensor on both of these electrodes with a cutoff temperature, so we're able to reach the desired temperature without exceeding. So any kind of energy-based device is all about energy control and temperature control, because the difference between a burn and soft tissue contraction really comes down to a couple degrees. And this is a fractional radiofrequency needling device called the Morpheus device, which we'll discuss shortly. So we tell patients when we look at facial aging, when you're young, your face is like an upside down triangle. And as we age, it becomes more of a right side up triangle with heaviness in the lower face and neck area, jowling, submental laxity. So the ideal patients for any of these energy-based technologies, really ideally the younger the better skin elasticity the better. So typically patients in their 40s or 50s with moderate jowling, moderate soft tissue laxity in the submental area. Ideally no platysmal bands, because these technologies won't correct any kind of muscular banding underneath. Similar to liposuction, we typically pre-treat patients with either some diazepam, pain medication, Pronox, as we mentioned in the previous portion, Dysuvia or sufentanil, or sometimes IV sedation as needed. But frequently these treatments are performed without any kind of sedation in the right patient. So here you're going to see a lower face and neck contouring case. So this is in conjunction with liposuction. And I want to share some of the considerations with you here. So there are markings. We mark in the seated position. We want to mark the borders of the mandible, because when the patient's in a supine position, it's harder to identify some of these borders. And we want to mark the jowls, and we like to keep this organized. So we mark the jowl above and below the border of the mandible. That's considered zone 1 and zone 2. And then we're going to mark the marionette line, which is an important landmark, because where I'm drawing this X right here is where the marginal mandibular nerve is going to become superficial. So both when we're performing just liposuction or when we're performing radiofrequency assisted liposuction or energy-based technologies, we want to avoid where the marginal mandibular nerve is becoming superficial to innervate the DAO muscle. So when we look at the facial nerve branches, we have a frontal branch, we have a zygomatic, buccal, marginal mandibular, and cervical. And what we worry about most are not the nerves in the middle, because there's a lot of cross branching. What we worry about are the end nerves, so the frontal branch and the marginal mandibular and cervical. Those are the branches that are at the edges, and if any kind of heat injury or even blunt injury from liposuction can cause a neuropraxia or permanent nerve injury. So we mark out an X right at the marionette line. It's about 2 finger breadths each limb to know that we're going to avoid this area. And then similar to standard liposuction, we're just marking out areas of adiposity so we know exactly where we want to remove any kind of lipodystrophy or fat from, as well as tightening the skin. So for our particular devices, there's 3 factors that play into soft tissue contraction. So temperature is an important factor, time, the duration of time you're applying that temperature, and distance from the surface of the skin. So our temperature settings typically are 68 degrees Celsius internally and 38 degrees Celsius externally, so we're able to monitor that. And this is just a demonstration showing you what some of our access points can be. It's very flexible. The most important thing is to avoid this red area. This is the case both for liposuction and for energy-based devices to avoid the marginal mandibular nerve. That's the major danger zone in the lower face and neck area. So here you can see a treatment. This is typically done before liposuction. And the reason it's done before is a fewfold. First, we have maximal tumescent in the tissue, which is acting as a heat sink. So the heat is not spreading too much. It also helps conduct the radiofrequency energy. The second variable is the fibroceptal networks, which are holding the skin to the underlying fascia. That's really our target. We want to heat those fibroceptal networks and allow them to contract almost like a parachute over the coming 6 to 8 weeks. So those fibroceptal networks are most extended when the tissue is tumesced versus doing it after the liposuction. So we prefer to do this before liposuction when it's performed in conjunction. This is just an image of a thermal image showing you that the treatment is effective. White is hotter, so we're able to identify what temperature we're at. Now, this particular device has an internal temperature sensor, so we're not depending on the near-infrared camera. We just use this as a secondary marker of temperature.
But face type done.
So this is a patient who had radiofrequency assisted liposuction, which means we performed radiofrequency first and then liposuction. This was all done under local anesthesia. Now, this is a good example of a patient who benefits from energy-based technology because we want to deliver energy to contract the soft tissue. So if you just perform liposuction on this patient, we would be concerned that maybe the skin won't necessarily contour to the removal of fat, meaning she may have some loose skin. And many patients are, this is not a perfect result. I think a neck lift would have achieved a better contour by removal of actual skin. But in this particular patient, she didn't want the downtime, she didn't want the incisions, so radiofrequency assisted liposuction was a good choice for her. There are smaller devices we can use for brow, we can use for jowl and just isolated submental areas, nasolabial folds. So that device in our practice is called the Accutite device. And then oftentimes we'll combine this with a fractionated radiofrequency needling device. Many people call this radiofrequency microneedling. And this is a nice additive device to add energy to the subdermal space and the reticular dermis. These devices typically have adjustable depths, so it can go as deep as 7 or 8 millimeters in some of the body needling devices, such as the Morpheus Body. This is the standard Morpheus device that's used on the face and neck areas or the body areas, and the depth goes up to 4 millimeters. So we're able to treat at multiple depths and deliver the energy at multiple depths to achieve some subdermal contraction. This is a bipolar technology as well. The energy moves from the tip of the needle to the faceplate, so we're really able to concentrate the energy on the reticular dermis. It's a coated tip, so the energy is really concentrated deep and not on the whole tip. We studied, many times there'll be criticism of energy-based devices. It causes fibrosis, it causes injury to lymphatics. So we actually studied this looking at perfusion and lymphatic assessment that was published in the Journal of Plastic and Reconstructive Surgery probably 4 or 5 years ago, which will include that article in your packet. And if you look at the results, this is a woman who had a facelift in the past. She has recurrent laxity in the submental area and the jowling. And this technology can be used in a revisional fashion to tighten some of those areas. Similarly, patients that have moderate laxity, mild laxity, who are bothered by submental areas and jawline shadowing can benefit from energy-based technologies. It's commonly used in the body areas in conjunction with liposuction and can really benefit patients who you're going to potentially be removing a fair volume of fat on, and you're just concerned in terms of how their soft tissue is going to contract. There are many areas in the body, such as back rolls and bra rolls, where you really want to get optimal contour, iron out these rolls. So in this case, we use 2 access points here centrally. You see one here and one here. We tumesced the whole back, just like I showed in the previous course. And then we performed radiofrequency treatment to the whole back to tighten, heat, and ultimately tighten these rolls. And then we used liposuction. Actually, we used ultrasound-assisted liposuction to break down the fibrous fatty tissue and remove it. But you could use standard liposuction as well. There are patients that just have crepiness of the skin. These are difficult patients to treat, and energy-based devices can be very helpful in improving the skin tone and texture in those cases. We didn't really talk about high-definition body contouring in the Lipo 101 portion of the course, but just for completion, there is high-definition body contouring. This is a result from Body Sculpt in New York City, where essentially you're performing liposuction and causing intentional contour deformities or intentional over-sculpting to correlate to the borders of muscle groups. So in the previous liposuction course, I showed you how we sometimes over-suction the semilunar line at the edges of the rectus muscle or the linea alba in the central line. But also what some providers do is high definition, where they will also essentially etch out the borders of the six-pack muscle and similarly take fat, that same fat that's liposuctioned, and graft it, fat transfer to the upper part of the pectoralis to give it more of a muscular appearance. The arms are a great place not just for liposuction under local anesthesia, but for energy-based technology too. This is a great article we've included in your packet on how this is performed step by step in the arm area. And what we do is we make a little access point proximal to the ulna, proximal to the ulnar nerve, to mess the arm 270 degrees and avoiding the bicipital groove. And then we perform radiofrequency treatment row by row, reaching an internal temperature of 68 degrees Celsius and an external temperature of 38 Celsius. And then we perform liposuction to contour the arm. So this is an example of a patient who had some skin laxity, some lipodystrophy, a really good candidate for radiofrequency assisted liposuction to remove the fat, contour the arm. And as you can see, this is not equivalent to an arm lift, but it also doesn't have the downtime or long incision that an arm lift would have. This is another example of a patient who's older, who benefited from the soft tissue contraction as well. So in summary, energy-based technology is a really important adjunct in many liposuction cases. It's important for patients to know that you're up to date with technology, you're able to do it under local anesthesia, and address mild to moderate soft tissue laxity at the time of liposuction, or in some cases on its own without liposuction. Thank you very much.
So what we're going to do is actually a body case with the face-tight handpiece. And the reason I'm using the face-tight handpiece is because it's a rather short area. So I think it's a nice application. The face-tight handpiece is probably the most versatile handpiece because it's kind of not too long, not too short. It's kind of right in the middle. So you can use it on body areas. And I think it's good to see that. So basically, when she was standing up, I simply marked the areas just like I would for a lipo case, because I am going to do lipo at the end of this. I always do radiofrequency first and then do lipo second. The reason for that is because your fibroseptal networks are most extended before lipo, so it's best to do radiofrequency first. It's safer too. So my technique here is pretty simple. I have a syringe, 10 cc syringe with 1% lidocaine with epi, just straight, and I'm just going to make my little access port here. And again, she doesn't have any sedation on. She's just, this is going to be a straight local case. And I already warned her ahead if she feels any pain not to say anything. So hopefully that'll be the case. So I just slowly infiltrate, you know, now I don't do it. So the nerves are like a tree, and you have a trunk and then you have branches. So the more superficial you are, the more painful it is. So I don't go right under the dermis. I don't create a bleb. I go just straight down. And you'll see this is my first step. So I'm just going to put a couple cc's in here. Just know in your mind kind of where you put that. So when you, because I'm going to come in with a 14 gauge needle and I don't want to miss that spot. So what I'll typically do is then I'll come more superficial and then I'll cause a little bleb just to indicate to me where I'm at. So I'm kind of right there. Then I have a 60 cc syringe with tumescent in it. So this is a 14 gauge needle, tumescent in it. So I like to create just a wheel. So I'm just going to go straight in. And I'm just going to infiltrate tumescent. You feeling that very much? Good. So she's totally good. Now, you don't want to see this peau d'orange kind of appearance because that indicates that you're pretty superficial. I kind of want to be right above the fascia. So, and if you hit fascia, they'll tell you. So you see, you may not have seen that, and I'll show you you'll see the video, but just now I felt resistance, and as soon as I get above the fascia, there's a plane. And the fluid just kind of flows in much more easily. So here I'm in that plane, and you see how easily it's going. I'm barely pushing on it. So now I have an area of local, and this is kind of what gets me in. So the goal is small areas and kind of move forward so the patient doesn't feel any pain. So I'm just going to get a nice wheel here. Now this is developing my plane. I know I'm right above the fascia, and that's where I want to be. Because I just want to treat the soft tissue as a whole. I don't want to, So in many ways, this is actually safer in the sense that if you hit fascia, the patient's going to tell you. I'm going to take a little 11 blade, just make a little access point here, nothing too large. And then I'm going to come in with my tumescent infiltrator. Just let me test it here. Okay. So you just kind of get in the area here. You okay there, Sam? Okay. So I'm just going to slowly infiltrate here. Up here. My cannula is always behind the area where I'm filling. And I like to get a good amount of tumescent in here because I don't want her to feel any pain. You doing all right there? You guys that trained me use what they call an A solution, which is 1 gram per liter. So it's kind of a lot actually. It's 100 cc's of 1% with epi or 50 cc's of 2% in a liter bag. Yeah. I use a lot less, so I'm using 30. I'll just take a 30 cc of 1% in a bag, and that's worked great for me. And so I don't worry about lidocaine toxicity.
With bicarb too?
Yeah, I usually put like 2 to 5 cc's of bicarb just for the burn. You feeling that at all? Just pressure. Yeah, so usually patients do pretty well. I have it pretty well filled. So I'm just, and you really want to just see it kind of filling ahead of you. So I'm just kind of going slow here, making sure the whole area is tumesced well. And I'm deep. I'm in that plane right above the fascia. And you see how it's kind of filling up nicely. So that's it. Is just come more superficially and just test myself. So you feeling any of that?
Yeah, this feels weird.
Feels weird, right? Yeah, some people feel ticklish, which is good. I mean, it's not good, but it's better than pain. And then, the nice thing, this accomplishes 2 things. These passes right here, it allows me to test my local. It allows me to kind of spread it out a little bit as well. And it gives me a feel of like, how much fat there is here, what I need to do. So ahead of time, I looked at this and I said, I'm probably going to lipo about 200 cc's. So I'm going to start with the radio frequency, and then we're going to do just a little bit of lipo. So I injected about 400. Okay. I usually go a little over. I do more than most people in terms of the tumescent. You could probably get away with doing, I don't know, 200 or 300. But I like the tumescent because it allows me to make sure that I'm safe with the radio frequency. It acts as a heat sink, and then I know I'm in the right planes here. So I like to tumescent. I don't want the patient to feel any pain, and then I have to come back and put more tumescent in. So I kind of just do it. Same thing with the face. I'll probably put 200 in. Not in her case because we're going to do Accutite, but on a full face. I don't need the tumescent to give peau d'orange look of the skin because I'm really going deep here. I want to develop that plane so when I do my treatment, I'm above the fascia. All I've used so far was a 10 cc syringe, a 60 cc syringe, a small like 27-30 gauge needle, and then a 14 gauge needle, and then a tumescent solution. So it's very kind of basic. 11 blade. This is the interface here. You hit the screen there. Yeah, perfect. You guys see the screen there nicely? So a couple things you'll see here. There's an external cutoff temperature, internal cutoff temperature. So that, like I said, I usually put that at 38, 68. Sometimes if I want to go a little higher, I'll go 70 internal. Treatment time is 120 seconds. This basically means it defaults to 15 seconds. So this basically means After that period of time, the device, you have to hit the pedal again in case you fall asleep or something. It's a safety mechanism. I think it's a required safety mechanism. So this is the face-tight handpiece, and usually we test it. So if I pinch the internal cannula, you see the internal temperature here starting to rise, so that's working. And if I touch the external cannula here, you'll see the external. So that means that I'm warm-blooded, and that means that the device is working. So whenever you change the settings, you have to press the standby button so that it puts you back into the ready mode. Anytime you change anything, you have to do that. Here you'll see the treatment time, the time that you've actually treated the patient, and then the total energy. You know, energy is not my endpoint, but it's useful when you're doing bilateral areas to kind of keep a record of the total kilojoules to just give you a sense of, you know, you don't want to get lazy on the second side, so it'll keep you honest. So we put some water-soluble ultrasound gel. You really shouldn't replace this with bacitracin or anything else. You'll get a burn. You may wonder how I know that. No, that wasn't you. So we just put a generous amount of gel on here. It helps with the conductivity. Okay, so here's our applicator. I'll probably make another hole here, but so I'm just kind of pre-tunneling, making it's very easy for me to pass through this area. And now basically I look at this very systematically. So I'm going to go row by row, heat this area to target temperature. You're going to hear audible alerts. The nice thing about the machine's behind me, I don't even have to look at it. And I like that. It sounds a little bit like a slot machine, which is ironic because we're in a gambling kind of area. But I guess patients are used to it here. But we're just going to go slowly. So when I hear a slow beep, that means I'm farther away from target temperature. And then as I hear a faster beep, that means I'm approaching target temperature. So when I hear a slow beep, I move slow. When I hear a fast beep, I move a little faster, and that's kind of it. So here, that's a slow beep. The double beep means I'm approaching target temperature. So I'm moving pretty slowly, staying in the same row. And you guys probably can't hear this, but there's some crackling. I can hear it from here, which is kind of a gratifying sound. So you see the temperature is approaching more closely. Now, part of the reason for that is because I put a little less tumescent here than up here. You can see how this is fuller than here. So the less tumescent you put in, the faster you'll reach target temperature. And as we reach target temperature, there's two kinds of fast beeps. There's a fast triple beep, like you're hearing now, and there's a slower one that goes dum 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 dum, and I'll show you that. So that indicates, the fast one indicates internal target temperature was reached, bless you, and then the external target temperature is the slower triple beep. So I'm just going to go back to that row. Now, if we had a FLIR camera set up, you would see a white kind of strip indicating that it's heating up. Good, so that noise indicates that the device was uncoupled for a second, which can happen when the internal and external probe are not aligned like that. So that noise doesn't really bother me. It just means that the device didn't fire. And as you get more comfortable, you can go a little faster and make sure you're heating that whole row sufficiently. And you want to put a little pressure. You don't need to crunch on it too hard, but you kind of want to make sure you're volumetrically heating those fibroceptal networks, and you're getting that whole area hitting internal and external temperature. Now, usually once I hit the internal and external temperature, I kind of stay there for about, 45 seconds to 60 seconds to make sure that I'm getting a good even heating.
Did you overdo it?
Well, so that's a good point, and I'll show you on the second PowerPoint. Now you hear this beeping, that means I've reached external target temperature. There. Now, a couple important safety considerations here. One thing you want to do is always be cognizant of where the internal cannula is. So I never cantilever up. I never want to see kind of the internal cannula under the skin, then you're too superficial. You're heating right at where this metal part is here, so it's a coated tip. So you really want to make sure deep is safe. So you want to make sure you're deep. You want to make sure you're cantilevering the device down. That's the major safety consideration. The The temperature is important, but your depth is more important because the radio frequency energy is really only transmitting half the distance between the two electrodes. So as long as the internal cannula is deep, you're safe. If it's superficial, then even at a lower temperature, you can have a problem. Now, if you do get a burn, which is quite rare, honestly, what'll happen is you'll see a little cigarette butt-sized epidermolysis. And what I usually do if that happens is just excise it and treat it like a lipoport and move on, because otherwise it'll evolve and you'll be nursing it and it'll just, not be ideal. So we're getting a nice even heating here, keeping my internal cannula down, just slow heating. The other thing you'll notice is I always stay about 1 centimeter away from the entry port because I don't want to heat it every time. What'll happen if you heat it every time is you'll get a little indentation there, and it's less, not ideal. Now the question was, can you overdo it? And I'll show you in the second PowerPoint. The device is smart, so once it hits target temperature, it's actually not firing, it's maintaining that temperature. So it's not consistently firing throughout the target temperature, it's just maintaining it. So you'll see target temperature is reached, and it just fires to keep that temperature up.
Once you reach the target temperature, how do you know how much longer to do it?
It's a little bit of arbitrary, but I would say normally I stay on in about 45 to 60 seconds, and that's kind of worked. I think if you hit target temperature and come right off, it's kind of underdoing it a little bit. So I think you do need to stay on for a period of time. But like you just pointed out, I mean, if you're not over treating by staying on there longer, you're just maintaining that temperature. You doing okay there, Sandy? You feeling anything?
Fabulous.
So she's doing good. She said fabulous. It's like a spa day here. And on our end, I don't know if you guys can hear the crackling, but we hear some crackling underneath. Thermage, which was the first radio frequency device for aesthetics used in 2002, 2003. It's monopolar. They really measure surface temperature more than internal temperature, and I think internal temperature probably matters more. We're really trying to affect the fibroseptal networks here. The other thing is, this doesn't really give you like a lift, kind of like how filler doesn't really give you a lift. It just contracts kind of globally, and I think that's an important point. Do you feel any of that on the edges? A little bit. So I usually mess a little past where I want to treat, just so, because the heat signature is going to travel about half a centimeter past the device, so you just want to be cognizant of that. Notice how I'm cantilevering down. I'm not kind of doing this, especially when you go over a curved area. Cellulite is a good question. How about there? Good, okay. Cellulite's a good question. I do think that this technology definitely remodels fat. Cellulite, I think, is a complex combination of issues. You get the fibroseptal networks pulling down on the skin. There's some fat contour issues. So I think it'll remodel fat for sure. Not really melt fat, but just remodel the surface of it. And also tightens the fibroseptal network. So I've seen cellulite improve significantly with radio frequency. It's just, it's not always so reliably. So I don't like, I'll tell patients, well, your cellulite will probably get better. It definitely won't get worse. But I wouldn't kind of oversell it. Morpheus too helps with cellulite in my experience. So there's not many good options for cellulite. I think Sulfina doesn't really work great. I've seen a lot of bad complications from it.
What complications have you seen from Sulfina?
Oh, so I've seen bad hematomas, like really bad. That's actually caused major contour deformities. I can show you some pictures. I think the disposable cost is pretty high too, just from a practice. Yeah. Do you use it a lot?
Yeah, no, I've never used it.
Yeah. It's basically subcision. It's basically a blade that just goes under the skin and cuts the fibers. For patients that have like a really thick soft tissue envelope, you feel that? Okay, good. You can stack the heat, so you can go deep and then go more superficial. So you're kind of like layering heat. In this case, we don't really need to do that. She's young, so the radio frequency is kind of, in her case, is kind of additive to the lipo. These are the best patients to do, though. The patients who have some adiposity. So this is just a 3 millimeter cannula, nothing crazy. So I'm just kind of coming in, just kind of debulking this area. So, this is a case where I could just do lipo and it would be fine. And I believe it would contract well, and I think she would
she would have a nice result. The radio frequency is kind of additive. So you see, the lipo technique, a lot of you guys do lipo, so I don't need to tell you, you could probably teach me about it, but I'm moving around more, I'm fanning. You feel any of that? Good, so she's totally comfortable. Again, straight local. So you'll notice there's no blood. This is a coagulation device, actually, so you're not really causing bleeding. I don't even worry about bruising because you usually don't get it. So the fat's usually very clean. It is a little bit liquefied, or I don't know about to say liquefied. It's not like an ultrasound lipo where it's liquefied, but I wouldn't fat graft this fat, personally. Although people do fat graft vaser fat all the time, so I think it's probably fine. I have a bunch of cannulas, but I like a 3 millimeter for me is good. It's just kind of a medium range. The other thing is, this fat happens to be pretty fibrous, actually. So the body type does help, similar to how an ultrasound lipo would, kind of break that up a little bit. Although, like I said, I think for true fibrous fat, ultrasound is probably preferable for that indication. Patient Sandy, you're 45, you said? 45 years old. So she's a great example of a treatment gap patient. Overall looks excellent. As we all begin to age, a little jowling, submental laxity. She has. I really want to focus on the submental area on her, actually. The jowls aren't too bad. And then we'll actually do a little nasolabial to show you. She's already prepped and everything. So let me show you actually how I would do lower lid, and then I'll show you how we do nasolabial, jowl, and submental with the Accutite, and I'll describe it with the FaceTite. It's basically the same technique. Now, the reason I'm not doing FaceTite on her, are you guys able to see pretty well? Okay, good. The reason I'm not using FaceTite on her is because, most of her neck is actually pretty good. It's mainly just the submental area. So the Accutite is 6 inches long. It's just long enough that I'm just going to get the target areas I want to hit. And it's a very kind of convenient way of doing it. So for the lower lid, I'm not actually going to do lower lid on her because she doesn't really need it. But what I would do is here, you palpate the orbital rim. It's kind of right there. Just come lateral to it, so like right here, basically. I would make a little wheel of 1 cc lidocaine here with a 27 or 30 gauge needle. I would come in with that tumescent fluid, about 10 cc's of it, with a little bit of a larger needle, maybe a 16 gauge, right on the periosteum. And when you're in the right plane, the whole SOOF will just kind of fill up with 2 cc's, not even. So you're really where you want to focus. So here's the tarsal plate. Here's the orbital rim. So I want to be right in between here. So that's exactly kind of usually just the width of an Accutite. So you want the internal, so you're going to put the internal cannula in through a 18 gauge needle poke. The cannula is going to be right on the orbital rim. And you close your eye for me. So you see where on her, she doesn't have much fat herniation, but for people that do, you'll see it right there. Your internal cannula will be right on the orbital rim, right on the periosteum. Really scrape the periosteum. You'll know you're in the right plane. It's a couple passes back and forth, and that's it. You hear the triple beep, you hear the slower triple beep, and you're there. So that's lower lid. The thing to be cognizant of is you always want to make sure your internal cannula is deep, and you can get superficial here because you're going over a curved area. So just make sure your internal cannula is always on the periosteum. Put enough tumescent in so that it's really kind of blown up, so you really define that space and you're totally safe. For the nasolabial area, I'm going to show you how to do it. We're going to do it. So I mark the nasolabial fold itself, and that's going to be the inferior border of my Accutite treatment. So I'm not actually treating the fold, I'm treating the above fold. So yeah, my Accutite's going to kind of be right there because I want to efface the fold. Sometimes I'll combine it with a little radius in the periapical area. I like that combination. Just put radius right there as a depot, and it really effaces the whole fold quite nicely. So we'll do the same thing on this side. And my access is going to be right. I'm just going to do a little poke here. So this is Accutite's really easy for isolated areas, just like we're going to do. Now, I'm going to mark her out as if I were going to do a full FaceTite, and I'll show you exactly kind of what's involved here. So I'm going to have you look at the window there. Perfect. Good. A little more. Okay. So I'm going to mark the border of her mandible just as a reference. And the only reason I'm doing that is because I just want to define the gel above and below that line so I can systematically heat it. So she doesn't have too much of a gel, but let's say that's zone 1, and this is zone 2. So this is the area we want to heat. Now, when you're doing face tight, AccuTight, you have a couple options for access points, and we'll go through the PowerPoint of it just to show you kind of our options. But what I typically do is I'll go inferior to the ear lobule, about 1.5 centimeters or so. That'll be one access point, and then I'll treat the neck as a flat plane this way. I'll do the same thing on the other side. So not posterior, but inferior. The problem is if you go posterior, you're fighting the sternocleidomastoid, you're trying to go over hills and valleys. You always want to treat things as a flat plane. That's the best way to get a good treatment. And then I just go submental, which we're going to do with the AccuTight here. So that's typically how I'll do it, and the face tight will reach all the way to the central area. So it's the same technique we used on the body area. It's just with the face. Now the only kind of danger zone here is the marionette line. We just come down, follow the marionette line. So I like to kind of cheat it out a little bit. It just keeps me a little bit safer. So let's say her marionette line is kind of like that. Where these two lines collide is kind of what I want to avoid. And I draw a pretty generous X there just to remind myself this is a no-fly zone. Now you'll notice that marionette line usually falls right on the pre-gel border. So you have a couple options here. What I'm going to do with the AccuTight, because this is my main target area right here, is I'm actually going to come in medial to lateral. Because what that allows me to do is I'm going to treat this area maximally. And because I'm going to stay away from the entry port, I'm also avoiding the X at the same time. So it's a nice way to do it. And I like doing that with AccuTight because it's a small access point. It's just a needle stick. I'm not putting an incision on the central face. So I can treat this whole area with the AccuTight from a medial to lateral approach. Now, if I wanted to, I could just as easily come in through here and do face tight across the whole lower face and neck. Same thing. What else? So as far as treatment area goes, typically I'll go from tragus to corner of the mouth and down. So with a face tight, you can do that whole area and get a nice contraction of basically the whole lower third of the face. I'll usually go to the thyroid cartilage here. I mean, I don't really have a good reason for that, but typically, you know, I don't need to go much lower. So about, you know, to the first neck crease or thyroid cartilage here is about where I'll go. So it's pretty much the same technique here. I'm going to just come in just here, pinch, kind of go straight deep in and just slowly make a little wheel. Okay. And then, yeah, thank you. So usually I just do a couple cc's. So a 10 cc syringe is good enough for me just to get in at all these areas together. So submental, and then we're going to do pre-gel here. So I really like AccuTight for the face because you can just kind of hit all these areas. I don't even worry about bruising. I don't really get into bruising too much because it is a coagulation device, so it's not something I even talk to them about necessarily. They will be swollen from the tumescent, so that you have to tell them. So you'll be a little swollen from this here, Sandra, from the tumescent. Mm-hmm. You okay? You feeling that a little bit? Mm-hmm. And once you have the local technique down, I mean, everything else is pretty easy. So this is just the 1% Lido with epi. And we're just going to inject some tumescent. So in this case, I'm going to just do it with the 18 gauge because it's such a small area. I don't really need a whole tumescent cannula setup.
Are you going to give me dimples?
Let me have you look that way. So here's my little poke. So I'm just kind of going in. And then I'm just going to slowly infiltrate on my way up. It's not very much. It goes in pretty easy. You feeling that very much? So she's not on any sedation, you know, this is straight local. Again, I'm pretty generous with the tumescent. Some people are less generous. For small cases like this, now if I'm doing a full face, then I will use a tumescent cannula because I kind of got to get through the whole neck, and so it's a little bit more involved. You feeling okay? Is it pressure or is it
Combination.
combination? Okay. Is it sharp?
No.
No. Don't be too tough here. Now in the neck, you want to be, again, in the pre-platysmal plane. Everything here is about being above muscle. So I don't want to see that peau d'orange kind of look. I just want to see how it's just filling. So that's kind of what I want. I just want a slow filling. The submental kind of bothers people most because it's a little unnatural pressure. You feeling okay? Okay. So again, I usually tumesce a little more than the average. But see, the nice thing about this is now I have an access point at each of these places. So here's the Accutite. I'll just show you in relation to my finger. So it's about, you know, you don't really know what the length of my index finger is, but it's about 6 inches. This is 18 gauge. So here's where the energy is coming out of this. It's a coated. It's only coming out of the tip. Everything else, the rest of the cannula is coated. So let's start kind of top down here. So we have some gel. We have this tumesced. I already marked out the fold. Have you put your chin down just a little bit. So again, this is a place where you can become superficial medially because you're coming over the curved maxilla. So you just want to kind of cantilever down. You feel any of that? So you heat up these areas very quickly with the Accutite. It's very efficient. Again, stay away from the entry port here, about 1 centimeter. So these Accutite treatments are extremely fast. Don't expect to hang out here very long. See how fast we reach target temperature? It's a small area of tissue. You see how my lower limit is the dotted line. So now we've reached external temperature. So I'm just going to hang out here for a couple seconds, 30 seconds or so. I'm pretty deep. I'm cantilevering down. 1 row, very easy. So you could do these all day, you know, nasolabial. I prefer this over filler. Now that I'm at external temperature, the device is only firing to maintain that temperature. It's not firing constantly. So that's it.
Kind of feels good.
Does it feel good? See that? Feels
It's like
good.
a warm massage.
I'm going to do side by side, so let me just do the gel here. Now let me just tell you kilojoules. We put in 0.3 kilojoules in that area. It just gives you a number. So let's say we're going to do a face tight of the whole lower face and neck. That would be probably 10 kilojoules or 12 kilojoules, depending on how much tumescent you put in, how big the neck was. So, you know, for lower lid, it's probably going to be 0.2. For nasolabial, probably be 0.3. Just to put a number to it. A larger gel, maybe 0.4, 0.5. So it just gives you a reference point. Another thing I'll do often, like smile for me right now, Sandra. Okay, so usually what I'll do is I'll have her smile before I do the local, right after the local, and then right after the RF. So at least I'll know, you know, what's the contribution of a potential local effect on the market, just for my own, you know, peace and comfort. So that's external. Most people's gels are only going to be like 1 or 2 rows with the Accutite. It's not very much. You feeling pretty good?
Mm-hmm.
So that's external temperature we hit just now. Again, here the tendency is to go straight up, but you'd be pretty superficial here if I do that. So I really want to kind of be very cognizant, cantilever down. I have a lot of space because that tumescent just really put the platysma down and everything else up, so I'm good. That's why I like to tumesce a lot. So I'm really holding it down. And if you need to use your other hand to just kind of stabilize things, you can. You doing all right? So now I hit internal, so now I'm going to go a little faster, get my external. I'm kind of always looking, make sure I don't see any epidermolysis or superficial area. She's falling asleep on me, which is kind of good. Good local. Now, if you take a break, like I'm just doing right now, you will have to kind of reset the clock because things will get cool and you kind of have to consider that, which is fine. There's no problem in kind of retreating an area. I found. So this is our patient's abdomen. She has a little bit of fullness here and a little bit of a depression here. So it's kind of a tough case because, you know, you want to get this down, but you want to make sure after 5 kids that she kind of tightens up. So what I'm going to do here is actually go periumbilical. We're going to do radio frequency and then lipo to get this down. Do the same thing a little bit on the inferior and lateral side towards me, and then we're going to do a little supraumbilical area here. So a little pinch. So it's all the same. Kind of go straight in, a few cc's. So she had 2 Valium as opposed to the other patient, so she should be pretty comfortable. So really for body areas, it's pretty, it's all just the similar technique. You know, when you're doing an abdomen, you always have to think about the curvature of the abdomen. So when I come in with the body tight, I don't want to come straight across. I have to kind of curve with the abdomen. Pinch. But the beauty of this is, you know, it's all office-based. It's quite straightforward. Now, the reason I'm not, you know, initially I would normally come down here, but she already has like a little bit of a contour indentation here, so I don't want to kind of exacerbate that, so I'm going to kind of just come this direction. So that was the direct, that was the local there. I'm just going to kind of come in here. Do you feel that at all? Okay, good. So again, just I want to get like in the suprafascial area. So I'm kind of going pretty deep. I don't want to feel any resistance here. So see how easily it's going in and just filling up that space, so I know I'm in the right place. And you know, I'll just do the same thing on this side. You feel that there? A little bit. So here we go. I'm in the right plane here. I mean, as a plastic surgeon, I just have a tendency to prefer lipo RF just because I know how reliable it is. I know how, I just know how it's going to work out. So you guys see here, I'm cantilevering down like this. I'm not coming like that because it'll be superficial here. I'm just kind of tighten these areas. So moving slow. You feeling okay? Good. You feeling that medication kicking in? Not really. After 5 kids, you need 5 Valiums. Okay, so that's external there. What I'm going to do is I'm going to treat this hemiabdomen, and then I'm going to lipo it a little bit. Sometimes they're just sensitive, like just like in this case, in certain areas. And it makes it harder for sure because you want to thoroughly kind of treat the whole abdomen and optimize. But you obviously, you know, they will tell you when they feel pain. So I think the key thing is just use a lot of tumescent. Use a large cannula for tumescent, so you really make sure you're spreading it and you're breaking through scar tissue. You know, the cannula on the body tight and face tight, it's strong, but it is flexible. And, you know, I haven't had an issue of like misguidance into fascia, but you do want to make sure it has a clear path for sure. So that's just something to consider. But I've done it on patients that have had X-laps. I've had it on patients, you know, many previous operations. So it's not a contraindication. So let me just do a little more lipo on this side.